Right, so good evening once more again, senior colleagues and colleagues. So today, Dr. Asore Ogeneware will be taking us on alcoholic cardiomyopathy. After his presentation, would come in questions and contributions. So Dr. Asore, you have the floor. Thank you.
Okay, thank you everyone for this opportunity to present in this wonderful forum. So I'll be taking this topic, alcoholic cardiomyopathy. Alcohol has been ascribed as a crucial factor in death due to infectious disease, intentional and unintentional injuries, digestive disease, and several non-communicable diseases, which cardiac manifestations are some of the very severe non-communicable diseases that alcohol is being ascribed to. I'll be going through this outline, my discussion. So alcoholic cardiomyopathy, ACM, which I will use as an acronym going forward, belongs to a group of cardiac diseases called toxic cardiomyopathy, TCM, which develops as a result of exposure to cardiotoxic agents, with alcohol and chemotherapeutic agents are the most common etiologies. The pathophysiology of TCM is diverse depending on the offending agents, but the focus of this discussion is on the effect of alcohol on the myocardium and its role as a cause of heart failure due to dilated cardiomyopathy. ACM is a cardiac disease caused by chronic alcohol consumption. It is a clinical diagnosis made in a patient presenting with a constellation of findings that include a history of excessive alcohol intake, possible physical signs of alcohol abuse, heart failure, and supportive evidence consistent with DCM. Hypertension due to alcohol may be a confounding comorbidity as it contributes to left ventricular dysfunction, therefore must be differentiated from pure ACM. The major risk factor for developing ACM is chronic alcohol abuse. So we can't be talking about ACM when a patient is not taking alcohol. However, there is no cutoff value for the amount of alcohol consumption that will lead to development of ACM. ACM can be diagnosed by the following criteria. 1, DCM as seen on 2D echo, left ventricular end diastolic dimension greater than 2 standard deviation above normal, left ventricular ejection fraction less than 50%, and exclusion of hypertension, valvular diseases, and ischemic heart diseases. On epidemiology, ACM is a leading cause of non-ischemic DCM in the United States, with about 21 to 36% attributed to ACM. Incidence range between 1 to 2% in all heavy drinkers. And male age commonly range between 30 to 55, with significant history of alcohol for more than 10 years. Female constitute about 14% of all cases of ACM. However, are more sensitive to alcohol cardiotoxic effects. The morbid mortality rates are higher in males than females, and more in blacks compared to the whites. There's positive of data in Africa and Nigeria in particular. I tried to search around. I saw only one study, and it was an autopsy case at UNTH, where a middle-aged man who presented with florid symptoms of heart failure. But on autopsy, they found out they saw those histopathologic features in keeping with alcoholic cardiomyopathy, because the patient also had significant alcohol use. So the metabolism of alcohol. Although alcohol is not a nutrient, it is consumed in large quantities all over the world, hence becoming a major medical and social problem. Alcohol is metabolized by several processes or pathways. The most common of these pathways involve 2 enzymes, the alcohol dehydrogenase and also the aldehyde dehydrogenase. These enzymes help break apart the alcohol molecule, making it possible to eliminate from the body. First, the alcohol dehydrogenase metabolizes alcohol to acetaldehyde in the liver, which is a highly toxic substance and non-carcinogen. Acetaldehyde is further metabolized to a less active byproduct called acetate, which is then broken down into water and carbon dioxide for easy elimination. Of note is that 1 unit of alcohol is eliminated per hour. Therefore, it is advised to spread drinking time. Other enzymes like cytochrome P452A1 and catalase also help break down alcohol to acetaldehyde, only at times of large alcohol consumption. Ethanol produces 29.3 kilojoules of per kg, which is about 7 kilocalories of calorie per gram. But many alcoholic drinks contain sugar, which increases their caloric value. Therefore, a pint of beer provides about 250 kilocal, so heavy drinkers are unable to lose weight. All long-term effects of excess alcohol consumption are due to the ethanol in the alcohol, but short-term effects such as hangovers depend on additional substances known as congeners. So this is a schematic representation of the metabolism of alcohol, which particularly comes as ethanol. So it's converted to acetaldehyde, as I've explained previously, by alcohol dehydrogenase, which is further broken down to acetate and leaves the body via as carbon dioxide and water. So with heavy drinkers, there will be less time for all these pathways to take place. So there's more exposure of acetaldehyde, which is a very toxic agent to the human body. This is just a diagram for us to understand quantification of alcohol. Because most of the time in the previous books, we use units most of the time, but now we read books now, we tend to see standard drinks. So these are examples of standard drinks. I think it is important that we understand what a standard drink is, because most of us know about the units. We know a bottle of beer, it's 3 units, which is 30 grams. But now they use more of standard units to quantify the risk. So a normal glass that people use to drink that we have in our homes is a 1 standard drink, which in some books we put as 355 mils, which as depicted in this diagram, while some other authorities will put it as 341 mils. Why those normal wine glasses is also a standard drink, which is of less mils, and the whiskeys are of smaller quantity and is still 1 standard drink. So depending on the number the person is taking, the more glasses the person takes, the more standard drinks and the more risk to cardiovascular diseases and cancers. So for the pathophysiology, it's diverse. Ethanol causes myocardial damage via several mechanisms. Firstly, it has a direct toxic effect on the myocardium, and also from deficiencies of certain vitamins, minerals, and electrolytes, and also additive substances that are found in alcohol, like lead, cobalt, may also damage the myocardium directly. Ethanol impairs excitation, contraction, coupling, mitochondrial oxidation, phosphorylation, and cardiac contractility by adversely affecting the function of sarcolemmal membrane, the sarcoplasmic reticulum, the mitochondria, and contractile proteins. With sustained exposure to ethanol, myofibrillar degeneration and replacement fibrosis subsequently appear. In addition, acute or chronic consumption may adversely influence myofibrillar protein synthesis. Microscopically, the hearts of chronic heavy consumers of ethanol manifest an increased accumulation of collagen in the extracellular matrix, as well as increased intermolecular crosslinks. The pathophysiology of ACM also involves interactions between genetically related factors, such as the HLA subtypes or the alcohol dehydrogenase enzymes allele, as well as non-genetic factors, including thiamine deficiency and exposure to various substances that are directly cardiotoxic. This causes activation in compensatory mechanism in response to cardiac dysfunction, such as renin-angiotensin-aldosterone system, increased sympathetic activity, and increase in BMP release. These mechanisms are responsible for an increase in preload, left ventricular dilatation, and decreased cardiac output, which all contribute to ACM. So effect of ethanol on organ function, specifically the heart. Chronic heavy ethanol ingestion may induce left ventricular diastolic and or systolic dysfunction. But diastolic dysfunction caused in part by interstitial fibrosis of the myocardium is often demonstrable in heavy
Hello,
consumers.
Dr. Chief Asare. Sorry, please, there is a request. Can you put it on slideshow so that we can see it clearly?
Okay, I'm using my tab. I don't know how to convert to slideshow on my tab.
Okay, you're sharing. Okay, all right, understand. But can you put it on the page? Let me help you.
Okay, just give me a minute.
Okay, thank you, sir. I think some persons are not seeing the right. Thank you, Olalekan, for drawing our attention. Thank you, Olalekan.
Click on play, it will get on slideshow.
You say what?
Okay.
If I click on play.
Yes.
Okay.
Thank you. Thank you, Alex.
I clicked on play now. Current page, first page.
See current page. When you click on play, see current page.
Thank you very much.
Oh, excellent. Excellent. Thank you, my bishop. Thank you, Alex. Grateful.
Thank you. Okay. So effect of ethanol on organ function. Chronic heavy ethanol ingestion may induce left ventricular diastolic and or systolic dysfunction. Diastolic dysfunction caused in part by interstitial fibrosis of the myocardium is often demonstrable in heavy consumers, even in the absence of obvious signs and symptoms. About half of these asymptomatic chronic alcoholics have echo evidence of left ventricular hypertrophy with preserved systolic function. Ethanol may induce asymptomatic left ventricular systolic dysfunction, even when ingested by healthy individuals in relatively small quantities. But with continued heavy drinking, DCM may develop. The likelihood of ethanol-induced DCM developing correlates with the amount of ethanol that is consumed in a lifetime. Most men in whom it develops have consumed more than 80 grams of ethanol per day for at least 5 years. Some books will say 5 to 10, some books uses 10, but Brownwood uses 5, so that's why I used 5 here. However, females appear to be more susceptible with smaller amounts of alcohol per day and per lifetime. Individuals with light to moderate ethanol consumption actually have a lower incidence of chronic heart failure than those who do not drink at all. The effect of ethanol on systemic arterial hypertension. Individuals who consume more than 2 drinks per day are 1.5 to 2 times more likely to have hypertension than are age and sex matched non-drinkers. This effect is dose-related and most prominent when daily ethanol exceeds about 5 drinks. Social consumers is associated with a modest rise in systolic arterial pressure, whereas heavy or binge drinkers may lead to substantial increase. The mechanism here involves increase in plasma level of catecholamines, cortisol, renin, and aldosterone, each of which may cause systemic arterial vasoconstriction. Effect of ethanol on lipid metabolism. Ethanol consumption inhibits the oxidation of free fatty acid by the liver, which stimulates hepatic triglyceride synthesis and secretion of VLDL. Heavy ingestion may cause increase in serum concentration of total cholesterol and LDL, while regular ethanol consumption increases serum HDL. Subjects with hyperlipidemia should be encouraged to limit their ethanol intake. These are tables I extracted from Brownwood. The one to our left, which gives us a direction of the mechanism of ethanol-induced myocardial injury, while on the right are the effect of light and moderate alcohol intake and heavy alcohol intake on blood pressure and other parameters. You can just go through them. Thorough. And also effect of ethanol on arrhythmias. Ethanol consumption is associated with a variety of atrial and ventricular arrhythmias, most commonly atrial or ventricular premature beats, supraventricular tachycardias, atrial flutters, atrial fibrillation, ventricular tachycardias, or ventricular fibrillations. The most common, which is atrial fibrillation. Most episodes occur after binge drinking, usually on weekends or holidays, hence the term holiday hearts. This is a schematic representation of the effect of alcohol, how it starts, causes oxidative stress, leading to apoptosis, continued intake leads to apoptosis, reduced synthesis of protein, causes myocardial dysfunction and damage, and also fatty acid metabolism and transport. Continued drinking causes weakening of the myocyte and cell dropout, further causing left ventricular dilatation, thinning of the wall, hypertrophy as the case may be, decreased systolic and diastolic dysfunction, and progressively and finally causing DCM and symptoms of heart failure. For the histopathology features, for gross pathology of patients with the heart of patients with ACM, it is not different from patients with idiopathic dilated cardiomyopathy. But on light microscopy, there may be subtle differences like the interstitial fibrosis, myocyte necrosis with hypertrophy of other myocytes, and evidence of inflammation. On electron microscopy, we find the enlargement of the mitochondria and disorganization, dilatation of the sarcoplasmic reticulum, fat and glycogen deposition, and dilatation of the intercalating disc. For the clinical features, not still different from a patient presenting with florid heart failure or DCM. They present with shortness of breath, PND autopnea, bilateral leg swelling, palpitations, syncopal episodes, reduced systolic blood pressure, elevated JVP, displaced and diffuse apex, third or fourth heart sound, mitral regurgitation, also come with tricuspid regurg, pulmonary rales, hepatomegaly, and non-cardiac stigmata of chronic alcohol use. In evaluating this patient, the key to diagnosis is personal history of chronic heavy alcohol use and absence of other etiologies. As I said earlier, in a patient who does not take alcohol, ACM is already excluded. So in evaluating this patient, an echocardiography is very key and one of the most important investigation tool in making a diagnosis. Electro ECG is also important, chest X-ray, biomarkers. Liver function test is important in this patient because patients with chronic alcohol ingestion, we may see the AST-ALT ratio greater than 2, which will also give us an insight that this patient is having is an heavy alcohol consumer. And also a full blood count can also, when we look at the MCV, may be markedly elevated, which will also give us an insight of alcohol use. So for the echocardiography, there could be fourth chamber dilatation, and it could also be the left ventricle particularly must be dilated. It could be an increased left ventricular mass with reduced or normal wall thickness, systolic and diastolic dysfunction, mitral and tricuspid regurgitation. It could be features of pulmonary hypertension, intracardiac thrombi may be seen, left ventricular hypertrophy may also be seen as explained earlier. And the figure by the side, a diagram by the side is an echo and a 4-apical chamber echo that was done for a patient that I vested. We can clearly see that the left ventricle from eyeballing is markedly dilated, and there is almost a severe mitral regurgitation with the jet hitting the posterior free wall. ECG features are not really specific, but we could find premature atrial and ventricular complexes, SVTs, conduction defect like varying degrees of AV blocks, varying bundle branch blocks, and also QT prolongation. Chest X-ray is just in keeping with patients with idiopathic DCM or heart failure, could have those florid signs we all know about patients with heart failure. Then for biomarkers, I brought in the American Heart Association guideline for the biomarkers. Patients presenting with dyspnea, as we all know, biomarkers is a class 1 recommendation, meaning that it must be done for a patient presenting with dyspnea. Then patients that are hospitalized presenting on admission is also a class 1, but on discharge is a class 2A, which it should be done for them on discharge as case of monitoring and prognostication. So then the biomarkers we're talking about for emphasis sake is BNP and N-terminal proBNP. Then for evaluating generally a patient with heart failure, the other investigations that can be done for them, there are course, I brought out the class 1 investigations that should be done for patients with heart failure. Should do a complete blood count for them, urinalysis, serum electrolytes, serum creatinine, and the blood urine nitrogen or serum urea, as we commonly do in our centers, blood glucose, lipid profile, liver function tests, as I said earlier, and iron studies. So these are class 1 recommendations. For the treatment of alcoholic cardiomyopathy, it is not also different from management of patients with heart failure, like we all know. But the mainstay of treatment is to treat the underlying cause, which is complete and perpetual abstinence from all alcohol consumption. But studies have also suggested that decreasing intake to moderate level may be sufficient. The management should include providing patient resources and also counseling them. Standard therapy for any nutritional deficiency should be corrected, most especially vitamin B1, which is thiamine, and B12, which is cobalamin. Studies have also shown that those vitamins B1 and B12, they are speculated to be protective against apoptosis and protein damage. So while counseling patients for alcohol reduction or stoppage, this is the Canadian Association of Cardiologists. This is a diagram that I have vested also for us to also understand how to counsel a patient and the risk associated with the standard drinks as we talk about. So for zero drink or a patient who does not take anything at all, so we don't expect a risk for such a patient. For 1 to 2 standard drinks per week, it puts the patient at low risk. So those patients you will likely going to avoid alcohol consequences in such a patient, taking just 1 to 2 standard drinks per week. Then for 3 to 6 standard drinks per week, moderate risk. For those patients at risk of cancer, including breast and colon cancer. For 7 standard drinks and more, those patients are at risk of stroke and heart diseases. So we can also study this diagram so we can understand the standard drinks. And there's also some write-ups on how to counsel a patient on ways to avoid these complications from alcohol. So this is the GDMT, the guideline for managing patients with reduced heart failure or reduced ejection fraction, which we expect in patients with alcoholic cardiomyopathy. Is from the American Heart Association guidelines of 2022. So in a patient presenting with heart failure, having counseled the patient to stop alcohol, we manage them based on the emergency or how they come to the hospital. Because most of them, they already come in stage C. So stage C, you have to manage as an emergency when they come to the hospital. When we use the guideline-directed medical therapies, which are highlighted in green, and the ANIs are there, ACE inhibitor, ARBs, beta blockers are very important in these patients with alcoholic cardiomyopathy, mineralocorticoid receptor antagonists, and the SGLT2, then diuretics as needed. Then we can also escalate as the patient, if the patient does not improve, we can also escalate as depicted on the step 1 to step 6. And for prognosis, the natural history depends greatly on patients' ability to cease alcohol consumption completely. With abstinence, the prognosis are likely to recover are equal or better than idiopathic DCM. ACM has a better prognosis than ischemic cardiomyopathy. Atrial fibrillation, QRS with greater than 120 milliseconds, and absence of beta blocker therapy confers worse outcome. With continual consumption, the prognosis is grim, with mortality up to 50% at 3 to 6 years and up to 80% 10 years. In conclusion, I advise persons to find a way to reject alcohol. Thank you very much. Those are my references.
Thank you so much, Dr. Asore, for this extensive and excellent presentation. Your efforts is well appreciated. Okay, so the room is open to questions and contributions. Okay, so please, can you just recap the pathophysiology of alcoholic cardiomyopathy, please?
For alcoholic cardiomyopathy, it all starts with exposure to alcohol, as we all know. And alcohol, as I said, has a direct toxic effect on the myocardium on its own. Then other additives, like some alcohol, they have cobalt, some have lead. Those have all that kind of risk associated with ACM. Then alcohol on its own, they cause oxidative stress and activation of other neurohormonal system. This with time causes apoptosis and also causes degradation of proteins and also the intrinsic myocytes. So with time, it causes fragmentation, causes enlargement of the mitochondria, causes fragmentation on disorganization of the sarcoplasmic reticulum. This with time causes reduced contractility and dilatation of the walls of the chambers. There are still other studies or other postulation that has also provided insight into nutritional deficiencies like thiamine and other minerals, because most of all these heavy drinkers, they don't eat well. So when they lack all those vitamins and thiamine, these minerals and the micronutrients, they has a role to damage those myocytes and proteins, thereby exacerbating this cascade.
Okay, and one other question. Okay, there was a part I saw, even the mild drinkers, they still come down with asymptomatic systolic dysfunction. Even if they don't have so much alcohol intake, they can still present with some form of cardiac effects.
They still come with, yes. Most of those low to moderate drinkers, they can still come with, they usually come with diastolic dysfunction as the initial pathology, and also left ventricular hypertrophy, and they may be asymptomatic. But with excessive or continued drinking or alcohol consumption, it may now progress into DCM. So even low and moderate drinkers are still at risk because of that initial damage or initial cascade that starts with the diastolic dysfunction. So with time, it can exacerbate.
Okay, so like in summary, your presentation is saying we should not take alcohol, like abstinence, because even the little amount still has some detrimental effect on the heart. So that's the summary.
Yeah, that is what is currently preached. I had to go through, they're actually conflicting information about the use of alcohol. There are some studies or some texts that would tell you that moderate drinking, especially of wine, will help especially patients with ischemic cardiomyopathy or coronary artery diseases not to develop florid heart failure or not to make their condition worsen, as compared to non-drinkers. For non-drinkers, they are not protective on if they have ischemic cardiomyopathy. But the recent guideline from the World Health Federation, they try to dispel those aspects and try to even link it up with smoking, because they tell you that smoking, it is strictly written on cigarette packs about the effect of smoking. But in alcohol, those things are being concealed. So they are agitating now that those things should be strictly written on alcohol bottles, that any volume of alcohol taken has a detrimental effect. So the recent preaching is no alcohol. But the diagram I put in, let me just go straight to that. Let me go to that diagram. Okay, this one. You'll see some places where they tell you tips to help you stay on target. One, they say stick to limits you've set for yourself. Then drink slowly, because I said at the time that the body eliminates 1 unit per hour. So by the time someone drinks a large volume, it can only eliminate 1 unit per hour, meaning that those cascade of enzymatic metabolism will not be as active as it should be. So the person will be more exposed to acetaldehyde, which is the most toxic and carcinogenic breakdown of ethanol. Also, drink lots of water as you take alcohol. For every drink of alcohol, have one non-alcoholic drink. Then choose alcohol-free days or low alcohol beverages. There's also advice why you're drinking, and also have alcohol-free weeks or do alcohol-free activities. So these are some other aspects on how to actually try to reduce the effect of alcohol.
Okay, thank you so much. Thank you so much, Dr. Asare. Thank you. So going into the chat room. Okay. You're being applauded for a beautiful and lucid presentation. I'm not seeing any electronic hand up. Okay. Dr. Chief Ayodeji. Chief Ayodeji. See here. Dr. Ayodeji. Okay,
Yeah.
so what's your take on this? Where do you think should be an area of concentration, or from your little experience, what can you share with us as regards this topic?
For theory, I haven't seen more, but of course for MCQ, both the pathogenesis, the requirement for, the quantity for male and female, and then the various systolic and diastolic dysfunction that could occur from them. Maybe for MCQ, for others, I haven't seen. Because the theory we're going to, I haven't seen any past question, but maybe for MCQ, we need to pay attention to all those pathogenesis.
Okay, thank you.
Thank you.
Thank you so much. Okay, and Dr. Cyril. Dr. Cyril. Dr. Ozoke. Okay, Dr. Itubi. Dr. Itubi Ibrahim. Please, can you share with us what you think, your little experience on this topic? What you think your little experience here on this topic?
Okay, thank you very much. Good evening, consultants and other colleagues. Like Ayodeji said, maybe for the MCQ, going through past orals, I haven't seen much on this, but it's an important topic, especially now that we know that WHO has categorically stated, I think last year, that no quantity of alcohol consumption is actually beneficial. Before, there was a conflict whether small doses were okay and helpful, but I think the last communication from WHO showed clearly that there are no real benefits with alcohol consumption, and the mainstay in treating alcoholic cardiomyopathy, which geographically, depending on where you work, we see such cases as well. And the mainstay actually is complete abstinence. But many times it's not just a cardiologist approach alone. It's multidisciplinary. In taking care of this, you might need to involve the psychologists as well, and other people that can help such patients wean off. Then there's been something around binge alcohol consumption, even though we know that mostly is as a result of chronic alcohol use, but there's been a strong relationship with binge alcohol consumption as well. Essentially, but I think for MCQ, so that if we see things, maybe an area based on what WHO has said, there's no benefit of any quantity, so we can't just say reduction. Of course, when people are going to stop alcohol consumption, it may not be abrupt, so it might be a guided, stepwise guided thing, but the aim is for abstinence. Thank you very much. Thank you, Dr. Ashore. Thank you.
Thank you so much. Thank you so much, Dr. Alex. Thank you. We appreciate it. All right. Okay, so in the absence of further questions and contributions, I'll hand over the class to Chief Okopi. Chief Okopi, sir. Chief Okopi. Chief Okopi. All right. Okay, so I'll hand over the class to Chief Allison. Chief Allison. Okay.
Yeah.
Okay.
Yes, I'm with you. Thank you, Dr. Florence. Okay, I think Dr. Kofi is trying to talk.
Florence for that students
Chief Okopi, your network is dragging.
Can you hear me?
Oh, Chief Okopi, I don't know whether you go under the mango tree or top of the mango tree. We're not hearing you well.
Can you hear me? Yeah, can you hear me? Can you hear me?
Yes, better. Yeah,
Can you
better
hear
now.
me?
Yes, I
Hello?
can hear you better. I can
Hello,
hear you
Florence.
better now, too. I can hear you better now. I can hear you better, Chief.
Okay, all right, that's lovely. If you can hear me clearly, actually, in Port Harcourt, the network
Oh, yeah,
kind of.
Port Harcourt. Okay, that's nice. Welcome.
One of my friends said in Port Harcourt there are only 6 people that are normal, Florence and others. So, and the network too is contributing to every problem now we're having. The place is so hot. Wow. Well, that's by the way. Thank you so much, Dr. Asore, for that beautiful presentation. Coming from Jos to Port Harcourt is something else. I'm trying to adjust this night. All right. Thank you so much, Dr. Asore. Even though you were under the weather, you still made the effort to present. Thank you for that big sacrifice. Let's just call on Dr. Alison, please, if you can hold on a bit. Is there Adeyanju around? If there's none, Dr. Cyril, do you have anything to say before we move to Adeyanju, and then we'll call on Prof? Prof is on the call. Hello, Dr. Cyril. All right, let's go to Dr. Dr. Alison. Please, you can have the floor. Thank you.
Yes, thank you. Thank you so much, Dr. Asere, for your beautiful presentation. So just some minor comment. Yes, okay, let me start this way. If I may ask, what if they ask you that what quantity of alcohol will be significant for alcoholic cardiomyopathy? What would be your response? There's a difference between alcohol heart disease, alcoholic cardiomyopathy. Do you get my point?
Yes. For
Okay.
alcohol, thank you very much. For alcoholic cardiomyopathy, it's greater than 80 grams per day
Okay.
for at least 5 years. Put the
Okay.
person at risk of ACM.
Yes, we put you at risk. It's for the risk, not that it will cause it. Do you get the point?
Yes.
That will give you the risk, yes. So the point we are making, it is possible to have multiple risk in one patient. Do you get? The patients
Yes.
might not consume so much and might still have an insult because he has some other risk. So it's possible that a patient that consumes large amount of alcohol, you don't just assume that it's only the alcohol. There might be maybe a background and insult that will now make whatever quantity of alcohol you are taking like a double risk or a multiple risk. Maybe you have hypertension, at the same time have valvular disease, then unfortunately you are smoking, you are taking alcohol. You get the point. So you can have multi-morbidity in the same patient. That's the point we are making. So we can have alcoholic cardiomyopathy, we can have alcoholic heart disease. So there's relationship. So definitely, yes, what Dr. Itubi said, very, very correct. So earlier and late last year, So it's been said that there's no level of alcohol that is safe for the heart. So what we preach, what is being preached now, in case maybe they ask or you want to talk about this in our, is that because we all know that it's not easy, you have to involve multidisciplinary, like you said. So telling a patient that no level of alcohol is good for your heart, please just stop. That you've not really done justice to that management. So if someone takes someone is an heavy alcohol abuser or is addicted, you advise that you reduce it. So if someone that is not addicted, you understand, there is no high opening and all those things that we use to qualify addiction, that means the patient can actually stop. So that's the way we go about it. And for someone that has never or does not take alcohol, we encourage that you should not even taste it. So that's what was said now. So the J point does not really suffice again. Then, as part of then we should also note, yes, in the echocardiography, we should also note that just like we discussed sarcoscopic cardiomyopathy, we discussed PPCM, alcoholic cardiomyopathy is also a type of cardiomyopathy that we can have the heart function going back to normal in a large proportion of people as long as they abstain. So you see the patient comes to the clinic, ejection fraction might be 20 or less. Person abstains from alcohol, like we are preaching abstinence, and you see the injection person goes from heart failure with reduced ejection fraction to heart failure with improved injection fraction as long as it's more than 10% from the baseline. Then subsequently, the patient regains, you understand, the function to full normal, remove all the diuretics, and you just give on cardioprotective medications, provided that there is abstinence. So the left ventricular or the heart function, let me put it that we can actually go back to normal with abstinence in majority of people. So that's just to mention about the prognosis and the normal, what did Dr. Florence call it? Progression or the normal, what do we say it now? It's something we call it, I've forgotten now.
Natural history.
Natural history, thank you so much. So in case then we are hard, so we expect that they go back to normal, except in some very few. But if individual continues to drink, even if he's on guideline-directed medical therapy, the heart will continue to go down. That's just it. Then as part of the management too, nutrition, as well as then replacement of from vitamins, including thiamine, is actually very, very important. And they could ask how will you give thiamine in this thing? So the one we have available in our environment is the oral one, those cars. But that is what we have. But when we don't get, then we look for imatinib, that's the drugs, all these multivitamins that contains thiamine and gives to the patient in the setting of in case we can't get it, because at times it could be scarce. So we should take note of that. Then what was the last thing I was going to say? I think I've covered what I was going to mention. So by and large, it was a very good presentation. Thank you.
Thank you so much, Dr. Allison. Can I be heard?
Yes, Chief.
Yes, Chief, we can hear you.
Okay, all right. Let me just ask a question, then I'll make some contributions. Dr. Asore, so grateful for the effort. Please, can you throw more light on the sex predilections and differences with respect to alcoholic cardiomyopathy? If you're on the page, I shared an article about it. So I wasn't too clear because in one of your slides, you actually mentioned something about no difference with respect to male and female in the earlier slides. So I don't know if you can throw more light on it.
Okay, for sex differences, for males, the volume or the units that puts a patient at risk is more for males and less for females. So females with lesser quantity or lesser exposure comes down with more cardiotoxic effects. So that's just one of the subtle differences as per gender. But males, I think, but I think males, they come down with more severe manifestations compared to the females. But as I said, let me just recap again. Females with lesser quantity, they are exposed to heart, the cardiotoxic effect of ethanol. They are more exposed with lesser quantity compared to males. But I can't give the definite values for females.
Okay, maybe let me just start from the aspect of the ideal quantity of alcohol consumption. Recent developments have shown that the reason why they are debunking whether you have to take some level of alcohol before you come down with alcoholic cardiomyopathy, it's because of some of the following. You know, there are genetic variants of alcoholic cardiomyopathy with respect to the enzyme metabolic pathway. I don't know when you were reading if you saw the alcohol dehydrogenase 1B, aldehyde dehydrogenase 2B, ACE, and AGT, and all that. These genetic variants will determine the level of alcoholic metabolism, such that even if somebody takes little alcohol, it will influence the degree to which the toxicity will be on the myocardium. So as a result of a specific alcohol quantity that will result in alcoholic cardiomyopathy. Also, the difference response to stress has also been found. And some studies have actually shown some epigenetic modification in the DNA methylation of alcohol. And then the effect of family, that if a member of the family once had alcoholic cardiomyopathy, even at lesser quantity of alcohol, someone can actually come down with alcoholic cardiomyopathy. So that quantity is not really called into play. But with respect to female and male, from what I've read, females is not even the severity itself. Female tends to have lesser manifestation or even come down with alcoholic cardiomyopathy without even the quantity, because studies have shown estrogen to be more protective, while testosterone has more cardiac remodeling effect, fibrosis, and even depression in LV function. And that's the reason why even in alcoholic cardiomyopathy for females, it is commoner during their luteal phase, so of their menstrual cycle. So if a female probably is drinking around her luteal phase, the chances of her coming down with alcoholic cardiomyopathy is high, because during the luteal phase, there's increased progesterone, counteracting the effect of estrogen. So estrogen tends to be more protective. And that's why for premenopausal female, they tend not to have adverse effects of alcohol as much as postmenopausal. So females, that's if you check the wards, check most of the patients you find with alcoholic cardiomyopathy, you hardly find females. Most of them are males. So I actually put a study for you to see. And the reason is because of the estrogen protective effect, which has anti-inflammatory, anti-fibrosis effect, and also improvement in cardiac function and reduced cardiac remodeling, unlike the progesterone, which has similar effect as testosterone. So during the luteal phase of the menstrual cycle, female tends to come down more with alcoholic cardiomyopathy because of the decrease in the circulating level of estrogen. And then also there have been recent studies for cardiac biomarkers for detection, screening in alcoholic cardiomyopathy. Probably you can check them up, or maybe I can share them with you. Cardiac biomarkers, the general cardiac biomarkers we have, troponins and natriuretic peptides. And then, but then they've now also found out that you can actually screen for it using C-reactive protein, interleukin-6, TNF-alpha, and some oxidative stress biomarker, which are actually coming out soon. The MDA, as I mentioned earlier, and a couple of other specific biomarkers, and collagen type 1 and type 3, in case for MCQ. fibrosis biomarker, cardiomyopathy, collagen type 1 and 3, and then the MMPs, that's the matrix metalloproteases. And then they've also found some specific micro RNA biomarkers like the MIR21, MIR26, and MIR133. So these are early biomarkers for screening, especially if someone is drinking and you want to actually check the level and to predict if someone will come down with alcoholic cardiomyopathy. So these biomarkers will help us. Should I bring it in the exam? I can share the biomarkers on the page so that we can just add it up. It was just the female and the male specificity that actually drew my attention. So the reason why I just said, let me make that contribution. So basically for female, it is during their luteal phase that they actually come down more with alcoholic cardiomyopathy, and it's because of the decrease in the level of circulating estrogen and increased level of progesterone, which has a cardiac risk. And then the effect of the level of alcohol to be taken is all dependent on some genetic variations and the various genetic variants of alcoholic cardiomyopathy and the presence of family history and some epigenetic modification of DNA methylation in families. So for some families, they may just have very low level of alcohol and they will come down with alcoholic cardiomyopathy. So any level of alcohol can actually result in toxicity to the cardiac myocyte. I think basically, apart from that, that was an excellent presentation. So probably I'll share the cardiac biomarkers for alcoholic cardiomyopathy and then some interesting articles with respect to the female and alcoholic cardiomyopathy. Because general rule is to expect that females should come down more, but for alcoholic cardiomyopathy and the heart, they tend not to. And if you take a panoramic view of your patients you have with alcoholic cardiomyopathy, you have very few females. And the reason is because of the protective effect of estrogen. But postmenopausal is almost equal, both male and female. Some studies have shown. So I shared one of those studies on the page. I don't know if Prof is on ground. I can ask if he has any contribution. All right, I don't think Prof is on ground, but is there any other concerns that we can share before we call the presentation to a close and go to the next phase? Meanwhile, thank you again, Dr. Asore. I'll share those biomarkers and then those articles for you to read. Thank you again.
Thank you very much.
Thank you for the excellent presentation, and thank you, Dr. Flores.